Hello, everybody.
Hi, how are you?
It's Malka Stromer
And Janine Noble
from Sound Sports Imaging. And today we are here at Integrative Medicine for the Soul in Phoenix, Arizona. And we are going to be talking about scanning abdominal aortic aneurysms. So first off, we're going to have a little bit of a presentation, and then we'll get started. Okay. Indications for scanning the abdominal aorta. If you feel a pulsatile abdominal mass, if the patient is experiencing abdominal pain, if you hear an abdominal bruit, if there is hemodynamic compromise in the lower limb arterial system, this would be of value to scan the abdominal aorta. Now, in order to do a complete exam, it would be valuable to scan the abdominal aorta from where it cuts through the diaphragm all the way to the bifurcation into the common iliacs in both a longitudinal scan and a transverse scan. The aorta, as we know, is the primary artery of the abdomen. It originates at the left ventricle of the heart. It enters the abdomen at the level of the 12th thoracic vertebrae and carries oxygenated blood to the body. The normal aorta measures about 2 centimeters in diameter, and it is easily differentiated from the inferior vena cava by its pulsation, its thicker and more echogenic walls because of the muscular walls that arteries have versus veins. At the level of the 4th lumbar vertebrae, it bifurcates into the right and left iliac arteries. The iliac arteries, as we know, further bifurcate into the right and left hypogastric and external branches. Now, these are not what we're going to be assessing. The value of the aorta and assessment of aorta on ultrasound, we want to look at the distal aorta prior to bifurcation. That's the most common location for a AAA. We also want to see if there's involvements to the level of the renal arteries and renal veins, and if it involves the iliacs at all. So here is an image of the proximal aorta on ultrasound. We're going to be looking here, this is the area where it's cutting through the diaphragm, and we're getting a long length of the proximal aorta. And we can see the aorta has anterior branches. So the first anterior branch here is the celiac trunk or celiac axis, followed very closely by the SMA or superior mesenteric artery. So this would be an image that we're looking for of the proximal aorta. Again, the proximal aorta is typically not a place where we're going to be visualizing a AAA. However, a complete exam of the aorta would include visualization of the proximal portion. Again, just around this level, just inferior to the SMA, would be roughly the area of the renal vessels. And so if there's dilation in that area, that would be an indicator maybe that this AAA is involving the renal arteries as well. This is an image here of the distal aorta. You want to be able to visualize the aorta in a long axis, nice, clear anechoic tube all the way down. And what happens as you go even more distal, you will see a tapering of the distal end of the aorta as it's narrowing down and going to bifurcate into the iliac vessels. And as you can see from the scale on the side here, this is maybe a centimeter to a centimeter and a half of AP diameter. This is nice and normal, healthy distal aorta. Now, I want you to understand a little bit about ectasia and the difference between ectasia and aneurysm. Ectasia is actually just a general enlargement of the aorta. And when the aorta enlarges, it actually causes a kinking of the aorta. It's got to fit into the same space, even though it gets bigger. So there'll actually be an anterior and lateral kinking of the aorta. However, in an ectatic aorta, the aorta in AP dimension still measures in normal caliber. It is not enlarged from an aneurysmal perspective. We may see ectatic aortas in elderly patients. Okay. An aneurysm, as we know, are focal or diffuse swellings of a blood vessel, and they're categorized into what we call true and false aneurysms. True aneurysms are aneurysms that involve all three wall layers of the vessel, and false or pseudoaneurysms are those that involve only 1 to 2 layers of the blood vessels. An example of a pseudoaneurysm is a dissection. Okay. The vast majority of AAAs are idiopathic and are true aneurysms. 95% of these AAAs are infrarenal, meaning below the level of the renal vessels. 5% of these are also associated with iliac artery aneurysms. So it's important to follow that aneurysm and to see if it involves the iliac vessels. A large percentage of AAAs are asymptomatic. And so this could be a valuable tool, quick tool, to be able to screen for aneurysms in a patient population that it would be required. We also want to look for complications, such as branch artery occlusion or stenosis, rupture. We can have thrombosis, dissection, infection, and then obstruction and invasion of adjacent structures. Okay. So what do we do with ultrasound in assessing the abdominal aorta and a AAA? We want to, as I said before, look at the extent of the disease. Does it involve the renal vessels? Does it involve the iliac vessels? Is there thrombus? Are there calcifications? Is there rupture? If a AAA ruptures, it's most commonly going to rupture into the left lateral infrarenal portion of the abdomen. The size is measured from outer wall to outer wall in an AP dimension. And greater than 3 centimeters, it's considered aneurysmal. When an aneurysm reaches about 5 centimeters in AP dimension, that's when treatment is required. We want to assess the shape, and we can potentially use Doppler to assess the hemodynamics, meaning looking for blood flow in the vessel. Shapes of AAAs, we can have saccular, fusiform, bulbous, or figure-8 shaped. Most commonly, we visualize fusiform aneurysms. Here are examples of AAAs. Okay, so we are looking actually at the distal aorta, and you can see how that distal aorta bulges out in this section here. There's also even some internal echoes here. So that could be thrombus within there. And you can see that this is not a huge length of an aneurysm. You can see that the vessel actually narrows out again. However, the AP dimension of this aneurysm is at least 3 centimeters. This would be a cross-sectional image of the same area. You can see internal echoes and some anechoic area, which is probably the only area where the blood is flowing. Dissections are something else we can visualize. It's a type of pseudoaneurysm. And what we're looking for is we're looking for what is described as a double lumen. And we can actually see potentially an intimal flap. So this would be a diagram of the aorta. And in a dissection, you would see an actual flap creating what appears to be actually 2 lumens. So this would be a long image and a cross section of an aortic dissection. treatment of AAAs. We can actually visualize post-op grafts. We can visualize the grafts, and we can visualize to see if there's any leaking from the graft. We can look for fluid collections such as hematomas, lymphoceles, seromas, or abscesses. As you can see in this picture, this is a cross-section of the abdomen. On the right, we have the inferior vena cava. On the left, there's this very, very bright echo. And then actually all around it is clot. And this is a repair of a AAA. And in long, you can actually see the very bright echoes, the walls of the graft of the AAA repair. These two images here are showing blood flow. And we want to make sure we can assess that treatment to determine if there's any leakage through that graft or not. Pseudoaneurysms, another type of pseudoaneurysm is a very commonly associated post-femoral artery catheterization. And we get what's called the yin-yang appearance, with to and fro flow within a dilated blood vessel. So the blood is going into the vessel and then it's circulating out of that aneurysmal portion. And so with color Doppler, you get the different colors due to the changing direction of the blood. And so you get this yin-yang appearance. Back in the day, sonographers used to treat femoral artery pseudoaneurysms by just putting pressure on the neck of that aneurysm with their transducer. Nowadays, they use thrombin to close it off. Okay, let's scan. I'm going to show you the technique of finding the aorta and the IVC. And as always, if you have questions or want to learn more, please contact us at info@soundsportsimaging.com and check us out at www.soundsportsimaging.com. Let's get scanning. Well, we're going to share the screen.
So I should be a little careful here.
Perfect. It's reconnecting.
Keep talking.
Okay, so as you can see, our patient here is supine position. Most likely in the emergency room, you're going to have your patient in a supine position. What we're going to be doing is we're going to be putting our transducer in the midline of the abdomen. Then we can angle the transducer either to the right or to the left. As we know anatomically, the inferior vena cava lies slightly to the right of midline. The abdominal aorta lies slightly to the left of midline. So we're going to do that assessment and look to the right and look to the left to see if we're on the correct vessel. Now, it's very important, as we discussed, looking at the characteristics of the aorta, is that it's going to have bright walls, and it's going to have anterior branches, whereas the IVC does not have that. So we're going to place the transducer on the midline of the abdomen, and this is quite beautiful. Okay? No, we're good. Okay, so what we're looking at here actually is the proximal aorta. You can actually see the heart pumping and the aorta cutting right through the diaphragm. Okay, and we can also see very beautifully if we freeze right here. Good, and we're gonna just cine loop back if we can a couple frames. Forwards. There, good, perfect. That's okay. We're gonna come back and I'm gonna show you the anterior branches. Okay, you can actually see them coming in right there. There's one going south which is the SMA, and there's one going basically straight up anteriorly, which is the celiac trunk. So we're right at the level of the anterior branches. Now, if I angle the transducer slightly to the patient's right-hand side, we can actually see another vessel. And you can see that this vessel here is not as rigid as, you can see how this vessel is not as rigid as the aorta. It actually has a curvature to it. If the patient takes a deep breath in and holds it there, you can actually see a little bit of collapse of that vessel. And that's the IVC. Just relax, breathe normally. The IVC is going to change caliber with respiration. It doesn't have the rigidity of the walls there of the abdominal aorta. So as you can see, I am angling slightly to the patient's right, IVC, slightly to the left, I'm on the aorta, okay? And as you can see here, we have the SMA, this is SMA, and this is the celiac trunk, okay? Now what we're gonna do is we're gonna follow this vessel all the way down till it tapers down. You can actually visualize some shadowing right here. This is bowel gas. You are always going to be viewing bowel gas as you come down because you're scanning right through bowel. I describe this as just being able to scan through the fog and just drive through the fog as if you were driving a car. And we're coming down, and you can actually visualize too how anterior the aorta becomes as you go distally, okay? The bright echoes at the bottom of the screen here are the vertebrae of the spine, okay? And you can now visualize that aorta tapering off into the iliac vessels. You can angle towards the patient's right, and that's the right iliac artery, and then go back center and angle a bit to their left, and there's the left iliac artery, okay? What we're going to do now is we're going to adjust our depth, okay? So we can bring that vessel right up to the top of the screen, or the middle of the screen, okay? So you want to be true midline of the vessel. You can potentially adjust your gains to make sure that this is nice and anechoic. Oops, I'm pressing that as if it's my, as if it's my screen. But no, we're gonna freeze that, and we're gonna measure the anterior to posterior dimension of that anechoic tube. Yeah, from white to white. Perfect. This measurement is slightly oblique. We're doing this with multiple hands. You want to get this truly, yeah, that's good right there. Perfect. Good. It's like drawing it up and down, the true axis of that. And you can see that this is 1.4 centimeters in AP dimension. Nice and normal. But this would be the area of a AAA. Okay. Now what we can do is we can go in cross section, and we can go back up top, and we're going to adjust the depth again so we can see a little bit deeper. Perfect. And we are right at the level of the heart. We can now see in cross section the inferior vena cava, the hepatic veins draining into there. And as we come down, we'll see two vessels next to each other. Okay. And those vessels, the one on the right or the left-hand side of the screen is your IVC, and the one next to that is your aorta. Anterior to the aorta, you'll actually visualize, you can visualize quite beautifully, the SMA in cross-section. Let's take a deep breath in and hold. All right, let's freeze right there. Beautiful. In this image here, what you're visualizing is aorta, IVC. You can actually visualize a portion of the left renal vein coming across the screen, and the SMA. Okay, so this is the area of the renal vessels. You can see that left renal vein just coming right off, laterally off of the IVC. So this would be the level that we're looking for any type of renal involvement, okay? So we're gonna take a deep breath in again. Hold, optimize that. Oh yeah, that's gorgeous, right there. Let's freeze right there. Good. Now again, you can see how beautifully this left renal vein is coming across. It's going anterior, and you can actually see the lateral branches of the renal arteries coming off as lateral branches of the aorta. That is the exact location of where you want to see. If you see dilation in that area, that's going to be renal involvement. Okay, we're going to come down now, more inferior. And see, we scan through this wave of gas, that's transverse colon coming through, and it appears again. And we can see again on the right of the patient, we have IVC, aorta, and as we come more inferior, beautiful aorta, we're hitting belly button. That's why you get that shadow there. But what's gonna happen, now you see that one aorta split into, and two little dots, those are the iliac vessels, the bifurcation. Okay, so we've seen the aorta from most proximal at the heart all the way to the bifurcation distally at the iliac vessels. And we've done a complete exam of that aorta. Okay, this is a little bit today about scanning and looking for AAAs. We want to thank you again for joining us. And remember, Sound Sports Imaging provides solutions to all your ultrasound needs. Have a great day.
So when